Thanks a lot.
Good morning, everybody. It's Wednesday morning. Thank you for joining my presentation. Today, I'm introducing once again our very own Dr. Emmanuel Taban. He is a pulmonologist, author, and founder of the Lung Institute. He was born in South Sudan, where he fled a civil war and rebuilt his life through perseverance and education, earning his medical degree from Medunsa and then thereafter specializing in internal medicine and pulmonology. During the COVID-19 pandemic, he pioneered the use of bronchoscopy to save critically ill patients and became one of New African Magazine's 100 most influential Africans. Beyond clinical medicine, he is the author of the best-selling autobiography, The Boy Who Never Gave Up, which chronicles his extraordinary life story and his belief in resilience, education, and hard work as tools for transformation. Dr. Taban is a passionate advocate for healthcare access, youth empowerment, and leadership development in Africa. His life and work embodies perseverance, innovation, and compassion, values that continue to inspire both his patients and his colleagues.
Thank you, Leanne. I'm still alive. Thank you. Today we'll be discussing about really hypersensitivity pneumonitis, and I think the topic was inspired based on the patients that I've seen recently in the hospitals that are struggling because of ongoing exposure. And I thought maybe I could highlight that. The intention of the talk is not really to highlight that you must kill your parrots or kill your pigeons, okay? No, the answer is not that. The question is about actually when to seek medical help earlier. Should you have any other symptom? Because we don't know who might develop the hypersensitivity pneumonitis and who might not. Let's kickstart. So I'd like to present a case of Miss LL, a 27-year-old female, was referred from a local hospital with a history of progressive shortness of breath and worsening cough. Her symptoms gradually intensified, accumulating in acute respiratory failure at presentation, and she was actually ventilated. And she only was liberated from ventilation after high-dose steroid, and she was extubated, but even after extubation, she still persists to be sick. So this was previous, according to her, healthy with no known past medical history or surgical history. Environmental exposure, repeat frequent contact with pigeons, include feedings and cleaning their droplets around the household, suggesting possible avian antigen exposure. Despite 3 negative sputum tests and negative culture for Mycobacterium tuberculosis, she was empirically initiated on anti-tuberculosis therapy at the local hospital, and then she was referred for second opinion. When she came, this was her radiology. CT scan was done. And if you look at here, they're quite very diffuse nodules of varying sizes, but you could probably say miliary with some area of septal thickening and obviously with some ground glass opacities. That's what you see. And then, of course, we did a transbronchial biopsy because she was quite not well. So transbronchial biopsy comes as a chronic interstitial inflammation with a fluid organizing pneumonia, poorly formed granulomas, and multinucleated giant cells, in keeping with hypersensitivity pneumonitis. So there was mal-established fibrosis is identified within the interstitium surrounding the Manson plaques. There is no severe fibrosis or architectural distortion by fibrosis. So, definitions. So what's an HP? It's an immune-mediated interstitial lung disease which was triggered by repeat inhalation of specific environmental antigens, typically smaller than 5 micrometers. Historically, was previously known as an intrinsic allergic alveolitis. The crucial safety and understanding, not just an inflammatory disease, but often with a progressive fibrotic component. Prevalence often underestimated, varying geographically based on environmental exposure, and most of these patients sometimes get diagnosed as IPF, idiopathic pulmonary fibrosis, or connective tissue-related disease. So sometimes most people actually don't know because people never sometimes sit down and do a proper history taking. Pathogens of HP, of course, which is immune dysregulation, It's actually a pathophysiology. Really, it's a complex T cell mediated hypersensitivity reaction, which is type 3. Type 3 hypersensitivity reaction. Of course, that would be an immune complex, and type 4, which cell mediated immunity. And then you have antigen presentation in the lungs, obviously, of that small proteins. And then you've got alveolar macrophage releasing IL-1, TNF alpha, and IL-8 leads to recruitment and activation of T lymphocyte, which is that you talk about your CD4 and CD8s. And a CD8 T cell dominated the inflammations, not CD4, CD8, and results in more than CD4 lymphocyte lead to formation granulomas, because your CD4 is CD8 more than your CD4. The role of genetic susceptibility, again, that's very important. Not everybody who get exposed to those proteins will develop HP, and there's quite a great role of HLA associations and mutant-5 promoter variant in fibrotic HP. So the key cellular players, of course, those will be a lymphocyte, especially a T cells, macrophage, and fibroblasts. So the progression from the inflammation to fibrosis results from persistent immune activations and chronic injury lead to fibroblast activations and collagen depositions. So if you look, this is really alveolar change in the lungs. In terms of the healthy lung, you could see the alveolus are quite well nice, like grapes. And then, of course, in the emphysema, you can see breaking out of the walls. You get alveolar membranes break down. And then when you look in the patient with the HP, there's no breakdown. However, you have the thickening of the membrane. Okay, your epithelium is quite thickened because of the inflammations. And that means the diffusions normally decrease because of the transition of oxygen from the alveolar to the capillaries is decreased, and as a result, hence the progression shortness breath and cough because of the alveolar wall thickening. So if we look at the pathophysiology, of course, you've got your airway, you inhale antigens. And then once your antigens in the lungs, they activate your dendritics and alveolar macrophage, and then you have antigen presentations. And once antigen has been presented, then you have your expansion of your T and B cell lymphocyte, causing lymphocytic alveolysis. And then the result release, of course, when that the lymphocytes are activated, they release your IL-2, interferon gamma, and TNF alpha, which are potent anti-inflammatory cytokines. And then you have result in granuloma formations. But the problem with granuloma is not a complete one, it's what we call haphazard granulomas. And then you have your chemotactical factors, and then that lead to your fibroblasts, fibroproliferations, and pneumonitis. Potential mechanism that transit from the Th1 to Th2, shock, telomeres, and aging. Telomeres is quite a very hot topics in pulmonologist exams that they always wanted us to discuss about it to link to the chronic lung conditions, especially COPD and IPF. So in the past, there was quite theory that was put in place called two hits hypothesis, where a two hit mechanism has been proposed to explain why only some patients develop HP, not everybody. Of course, one of the first hit is suspectability. You have to have genetically suspectable to develop HP. And this is a predisposition that makes an individual more vulnerable. It can be due to genetic factors, such as though none are consistent identified yet, or heavy, prolonged environmental exposure to potential antigen. So if you, let's say you have a duvet that is made out of feathers and you're genetically suspectable and use the duvet for a long time, of course, then you will actually develop the HP because you have constant inhalation of the same antigen. Second hit, of course, is antigen exposure. This is the actual inhalation or trigger that caused the disease to develop or progress in a suspectable person. And this is really why, just to expand more about the immune tolerance, of course, where you're having the telogenic dendritic cells, where they low express major histocomputable class 2 and B7 with co-stimulator molecules, and lower antigen presentation capacity, and it results called the IL-10 and TNF beta productions. while in the active disease, it's more alpha and IL-6 actually. So you have your dendritic cells, immunosuppressive mediators, and then you've got efficient Tregs, which is T cell regulatory cells, immunosuppressive function, and those particularly will become asymptomatic subjects, I mean they never develop HP. And the other group, of course, where you have mature dendritic cells, which highly express also MHC, class 2 and B7 costimulatory molecules, and high antigen presentation capacity. And then they produce pro-inflammatory cytokine productions, which is IL-1 beta, IL-6, and TNF alpha. So if you look at contrast, really depends what antibodies, what kind of cytokines you produce. If you produce IL-10 and TNF alpha beta, you can tend to be more like asymptomatics, and as compared to if you produce the pro-inflammatory cytokines. And of course, you got the triggers will be a lot of viruses, proteins, and other things. And obviously, those patients will develop active HP. Immune tolerance, of course, where you have your body defense, and most individuals exposed to this antigen never develop HP. This is likely due to immune tolerance, where the body learns to ignore the harmless substance. So in life, sometimes people who learn how to ignore certain problems in life, they tend to do better than those actually who decide to become a psycho and act on it. So sometimes the immune system can actually become a psycho and act on the antigen that should not actually, that's actually harmless. So in healthy response, individuals may develop a very mild asymptomatic inflammation, such as lymphocyte alveolitis, or maybe mild cough. And then, of course, T cells are crucial here as they support the aggressive immune response from Th1 and Th2 cells that will otherwise cause damage. Experimental studies suggest that when these suppressions fails, the unchecked T cell activity leads to the disease. Now, what are the causes? Of course, it's diverse etiologies, the antigen spectrums. So really, I think for students, I know that we have fellows online. We look at about 3 really causes of HP. One's microbial antigens, and the second is animal proteins, and the third is low molecular weight chemicals. And then, of course, the fourth would be the emerging or cryptogenic HP. And I think cryptogenic emerging means we don't know the causes, means we don't have a testing capacity, but as time goes on, we will learn to identify them. So let's look at a close zoom into the microbial antigens, which is the commonest would be the farmer's lungs. So those will have thermophilic actinomycetes, okay, or mold or hay farm's lungs. And then you have fungi, especially the Aspergillus species from contaminated humidified, water damaged buildings, and of course, non-tuberculosis mycobacterium in hot tubes, what we call hot tubes lungs. And then the animal proteins, of course, with proteins found in feathers, droppings, and fur are frequent causes. This is common in bird fences, lungs, and animals handlers, or even people with down pillows and comfort. And then low molecular weight chemicals, that will be a certain small chemicals molecules, likely isocyanide or metals. That's zinc or nickel can act as a haptens. This means they bind to the body's own protein, forming a complex that the immune system then recognizes as foreign and attacks. So imagine cryptogenic HP, of course, cases where an antigen cannot be identified, causing diagnostic and management challenges. And one of the very interesting cases that I saw previous was somebody who was actually doing research on the rats, and then he on the snakes actually. Then what it does, it takes rats to feed the snakes, and actually develop hypersensitivity pneumonitis from the pee of the rats. Yeah, so you normally you have to really, your history must be very detailed, and you do having people in the labs also can develop HP. So these are low molecular weight chemicals. If you look at methyl isocyanate and say, as I said, certain chemicals can't actually contribute to the development of HP. Clinical presentations. Yeah, so clinical presentations, as I alluded before, the people has labeled HPS differently. And currently, if you look at the new classification of interstitial lung disease, and then I think based on the ERS Congress that we attended recently about a month ago, now they actually place HP into a group called bronchocentric interstitial pneumonitis, means it's more bronchial centered. So, but I think probably the classification of a non-fibrotic and fibrotic still stands. Non-fibrotic HP obviously is probably much more friendly, more reversible, if predominantly really inflammatory, where we call an acute HP. They develop flu-like symptoms, fever, chills, and malaise, cough, dyspnea within hours of heavy exposure. And this is normally reversible with antigen avoidance, which is very important. Subacute HP, sometimes difficult to diagnose in our context, but most patients come late. It's tend to be more incidence on onset of cough, dyspnea, fatigue, over a week or months with ongoing exposure. And then your fibrotic HP, characterized by irreversible lung scarring, progressive dyspnea on exhaustion, chronic cough, weight loss, and often mimics other fibrotic interstitial lung disease, such as IPF, worse prognosis. And the problem with fibrotic HP, most of the time because the lungs are badly damaged. But the clue is that you can see what we call the mosaic attenuations. That's really probably become a giveaway. But I think most people, those patients are missed. They end being put on a lot of antifibrotic therapy, or they just been monitored and they deteriorate, and the actual mortality become actually very high. So let's look at the two phases of HP symptoms and phenotypes. We having on the blue is non-fibrotic HP, and then obviously on the red is fibrotic HP. And if you look, persistent coughs tend to be more common in fibrotic HP than on the non-fibrotics, but again, still really provide dominant symptoms. And then shortness of breath also, again, is very alarming on the chronic. Fever and chills tend to be more common really on the non-fibrotics than fibrotics, and then chronic fatigue. Again, it's a problem. Patient can be debilitated that they cannot actually able to work. So diagnostic journey, of course, it's a multidisciplinary approaches. No single test can diagnose HP. It requires a comprehensive evaluation, piecing together clues from the patient history, imaging, and specialized testing, often involved with teams of experts. And you have to be, I always say, physicians like FBIs, you have to be kind of piecing out the puzzle together to make the diagnosis. That's why we don't believe in idiopathic. Does not make sense. Idiopathic means you have not done your work, or you have not actually spent more time to address the problem. Idiopathic means an opportunity for us to really to make different kind of opinion about the diagnosis. So you need exposure, of course, history, hydrogen CT scan. It's really prepared that if you do hydrogen CT scan for HP, must be between 0.5 to 1 millimeter slides. Cannot be more than 3 because you will not have a proper diagnosis. Have to be very thin slides. And I know most radiologists, they are not keen to actually do that. Pulmonary function tests, which can vary, and bronchoalveolar lavage and blood testing. In terms of diagnostic algorithm, a multidisciplinary approach, you need consensus guideline diagnosed based on combination of clinical, radiological, and pathological features. The key diagnostic pillars, of course, were exposure to antigen, which you need to determine that, detailed history, computable hydrogen CT findings, lymphocytic alveolitis on your bronchoalveolar lavage. Histopathological features, biopsy, of course, we'll discuss that further, and importance of multidisciplinary discussion, especially for complex or indeterminate cases. Hydrogen CT finding, of course, the hydrogen in the HP is unmasking the patterns. Key points, of course, you got in the classic non-fibrotic HP, you have central lobular nodules, often poorly defined, like our CT scan, ground glass opacities, and mosaic attenuation and air trapping on expiratory scans. The three density pattern is highly suggestive. Fibrotic HP features will be a reflation, traction bronchiectasis, honeycombing, less common than in IP, often upper and the mid lungs predominate. And we have that discussion of fellows to say why the HP actually really having quite more upper lobe predominated. It's just because in an inhaled antigens tend to go on the upper lobe. In the upper lobe, you tend to have more ventilation than diffusion. In the lower lobe, you have more perfusion than ventilation. That's why HP will have more clinical features more on the upper and mid zone than compared to a lower zone. Volume loss normally is always much later features, and may show features such as HP overlay with fibrosis. And fibrosis normally sometimes is turn off. Most people, when they look at fibrosis, they immediately conclude as a IPF. And this is your, I just want to look at this. They inhale small organ particles. When somebody inhales particles, obviously, which is one of the proteins, you get your bronchocentric inflammations, which is now the new term that when you talk about HP. And then you get narrowing. You can see bronchocentric. You can see there, that's your airway bronchi. And you can see the central lobular ground glass opacity there. And then here you can see your mosaic attenuation there. Nice is very small, and then you got your narrowing of small airway with time, and then you're ending this area of ground glass with some area of your geographical locations where you have a mosaic attenuation. And then you have 3 dimensions pattern. And then chronic ground glass, also you can see it from there. And then this, you can see these patients, obviously. This is a patient that presented with HP. You could see that this was at 6 months. And then this is time later, this developed fibrotic HP. This is your acute, and then your chronic. Bronchoalveolar lavage. I think we have a lot of hematologists here. We have a lot of TAMPAT here. I think bronchoalveolar lavage is very important in diagnosis, but sometimes it's misplaced because most pulmonologists will do bronchoalveolar lavage, and they look at lymphocytes, and then they say, no, it didn't make sense. It's unlikely to be HP. But present lymphocytes cannot confirm or exclude diagnosis. Let's have a look. So bronchoalveolar lavage is essentially evaluating suspected hypersensitivity pneumonitis. It helps identify inflammatory patterns and cell profile characteristics of immune-mediated cells. A typical bronchoalveolar lavage finding, of course, you have marked lymphocytosis, which must be 30 to 60%, okay? And that will predominantly be CD8 cells, okay, which is very, very important. You have to have a marker for that. And then less of CD4. So I always say it's more typical, like when you have someone HIV advanced, then to have more CD8 than CD4. Reduced CD4-CD8 ratio must be less than 1, not equal to 1. And then presence of plasma cells, mast cells, and poor macrophage, and absence of eosinophilias. Once you have eosinophilia, means that tells you 2 or more eosinophilic pneumonitis. So for fellows, it's very important. Marked lymphocytosis, reduced CD4-CD8 ratio, and presence of plasma cells, mast cells, and poor macrophage. That's very important for your exams. And then, of course, you have decreased lymphocyte compared to acute and subacute. So now when your lymphocytes decrease, that probably tells there will be subacute or chronic. And then in the chronic, what we call fibrotic HP, you have decreased lymphocytosis compared to acute or subacute. So when your lymphocyte is decreased, again, that does not tell you it's not HP. Could have been the fibrotic HP. Increased neutrophils and occasional eosinophil also can be found in fibrotic HP and may resemble idiopathic pulmonary fibrosis in later stage. So if you get asked, don't fall into that route because the lymphocyte is low, it's unlikely to be an HP. Okay, you must decide this is fibrotic or non-fibrotic. So bronchoalveolar lavage support clinical radiologically also and serological finding of postmortem diagnosis to help differentiate HP from sarcoidosis and SIP, but I'll give you a quite nice drawing there. So if you look now, how do you know differential diagnosis once you did a bronchoalveolar lavage? Obviously that once the patient got HP, we have lymphocytosis, low CD4, ratio of less than 1. In sarcoidosis, lymphocytosis, high CD4, CD8 ratio of more than 1. In sarcoid, you have more CD4 than CD8. That's why they're having well-formed granulomas. And idiopathic pulmonary fibrosis, neutrophil or mixed patterns. Eosinophilic pneumonia, you have marked eosinophil more than 25%. That's how you differentiate. And I remember that was question in my exams. Histopathological, when biopsy is needed. Of course, the key point indications is very important. And when diagnosed remain uncertain after non-invasive workup, classic histological trial, where they say on the biopsy will be a fully formed non-necrotizing granulomas, central lobular interstitial inflammation, which will be bronchocentric, is very important, interstitial pneumonitis, lymphocyte plasma cell infiltrates. Okay, and then we do the surgical lung biopsy. But and then fibrotic HP, of course, may show UIP-like or NSIP-like pattern, often with preserved areas of classic HP features. But nowadays, of course, there's new development that surgical lung biopsy is no longer needed. If in South Africa, we're having quite a few centers that can do what we call cryobiopsy without actually leaving the patient with a scar. So that has become an emerging, less invasive techniques. In my center, I've always used a transbronchial biopsy with 2.8 with very big needle. I managed to get a very good pieces. Depends how you actually if you experience on it, and you can get actually a big tissue. You can make extra diagnosis out of that. Prognosis and natural history, of course, the prognosis of HP, a tale of two phenotypes. The key points, of course, non-fibrotic HP, generally good prognosis with antigen avoidance and corticosteroid, potential for full recovery. In fibrotic HP, worse prognosis, often progressive irreversible lung function decline, high mortality rate compared to idiopathic pulmonary fibrosis if you don't remove the antigen. Factors associated with worse prognosis are presence of fibrosis on horizontal CT scan, old age, male sex, lower baseline, HPV and DLCO, absence of identified antigen, continued antigen exposure. And of course, somebody that's in respiratory requiring oxygen and those who are having ongoing exposure, the prognosis tend to be worse, and those with the pulmonary hypertension, especially associated with the clotting. Risk of acute exacerbation can be life-threatening. So the state-of-art treatment strategy, of course, will be the cornerstone antigen avoidance again and again. Avoid antigen. We need to identify what is the trigger. If you don't know the trigger, you're wasting your time. For all patients, the absolute priority is the strict and complete removal of the trigger. Without these, other therapies are significantly less effective. This may involve environmental remediations or even a career changes. Inflammation, non-fibrotic, of course, corticosteroid is the most important one. The first-line therapies to suppress the initial immune response and reduce acute inflammation, often leading to symptom resolution. For fibrotic HP, a multifaceted approach is used, include immunosuppression like mycophenolates, and major advance is the use of antifibrotic therapy to slow the rate of lung scarring and preserve function. Nintedanib has really got a lot of role to play in TNF alpha inhibition. Treatment principle, of course, the treatment is stop the cause, calm the storm. The key points, antigen avoidance again and again, absolute priority, crucial for both non-fibrotic and fibrotic HP, require digital counseling, environmental modification, sometimes career change. Without avoidance, other therapies are less effective. Corticosteroid, first line for acute, subacute inflammation and non-fibrotic HP. High dose initially, taper based on response, can be used in fibrotic HP to manage acute exacerbation. Advanced therapy targets. Advanced therapy, of course, will be fighting fibrosis and progression. The key point, of course, immunosuppressive steroid-sparing agents, mycophenolates, and azathioprines are the key drugs used in progressive fibrotic HP or when steroids are ineffective or contraindicated, or for steroid sparing. Aim at reducing chronic inflammation and potential slowing fibrosis. Anti-fibrotic agents, which is a game changer with nintedanib, approved for chronic fibrosis, ILD, with a progressive phenotype, include fibrotic HP. And this is, we have it in South Africa. Unfortunately, that's expensive, 13,000 rand a month. Okay, and there's trial to back it up based on in-built trial. Pepinidone, I think there's no robust data for use in HP, but they're quite trial there and there. And McKinsey, of course, target fibroblasts, proliferation, extracellular matrix deposition. So combination therapy is key, often immunosuppressive plus antifibrotic and progressive HP. Prognosis at glance. Obviously, if you have non-fibrotic HP, the prognosis, the cure rate is almost 80%. In fibrotic HP, it's about really 30 to 40%. So it's really could be bad. Quickly look at the parrots. We all love them. They sing. They make us happy. McKinsey of hypersensitivity pneumonitis parrots exposure is called bird pencil lungs overview caused by inhalation of avian proteins from the feathers of the parrots, droplets, and serum. So it could be any of them. They represent type 3, immune complex, and type 4 hypersensitivity. Type 1 pathogenesis, of course, you get your antigen exposure. You get exposed to the antigen, inhalation avian protein reaching alveolar, Then you have sensitizations where macrophage and undertake activations, IgE, antibody formation. Acute phase, you have antigen antibody complexes, complement activation, neutropenic inflammation. Chronic phase, you have your T cell mediated, this is your Th1 granulomas formation. And fibrosis, where you have your activation of fibroblasts, activation, and extracellular matrix deposition. And we need to avoid that path. Radiological or pathological correlations are acute ground glass opacity, mosaic attenuation, chronic reticulation and honeycombing, and histology, of course, you get bronchocentric inflammation, foliform granulomas. So the key mediators, of course, IgG, antibodies, CD4, CD8, T cells, IL, IL6, TNF-alpha, and then interferon gamma. And then this is so lovely. We all love our sleep. We will do anything to import the most expensive Duvets around the world to make sure that we have a night's sleep of that 6-8 hours of our lives. But sometimes it can be a problem. So the McKinsey Hypersensitivity Pneumonitis from Duvet inhalations. And the argument is that, look, it's still inside. No, it can't still. You can have micro inhalations. You've got, again, antigen source will be, most of them, again, they're down of feathers field, Duvet, pillows, and bedding contain avian proteins, such as serum, droplets, bloom dust. Over time, these particles are aerosolized and are inhaled deeply into the alveolar. Immunogenic sensitization, of course, you have repeated exposure lead to immune sensitization. And then type 3, immune complex, and type 4, delayed type, hypersensitivity reaction occurs simultaneously. Then antigens bind to specific IgE antibodies, forming immune complexes in alveolar walls. Inflammation cascade, activation of complement, and recruitment of neutrophils, CD8 T cells, and macrophages. Cytokine release, of course, will be TNF-alpha and IL-1 and IL-8, amplify the inflammation response, leading to alveolitis and non-caseating granulomas formation. Chronic damage, of course, we have persistent inflammatory cause fibroblast activation, interstitial fibrosis, and reduce your lung compliance. Clinical manifestation as progressive dyspnea, dry cough, and hypoxemia, often misdiagnosed as idiopathic pulmonary fibrosis. Pathologic hallmark, of course, histologically, you have cellular interstitial pneumonitis, foliform granulomas, giant cells with cholesterol, clefts. Bronchoalveolar lavage, again, lymphocytosis with 40 to 60% with CD8 plus predominate. Supportive care and future directions, because the key are comprehensive care and road ahead. Key point will be supported care, oxygen therapy for hypoxemia, pulmonary rehabilitation, improve exercise tolerance, and quality of life. In South Africa, those are not well developed, but I think in future we'll have a lot of center for pulmonary rehabilitation. Vaccines, you need to have your flu, pneumonia, and COVID vaccine. Management of comorbidities will be a gastroesophageal reflux disease because that also can exacerbate it, and treatment of pulmonary hypertension. Lung transplant for carefully selected patients with end-stage fibrotic HP. And then future direction, of course, will improve diagnostic biomarkers. It's very important for especially for cryptogenic and idiopathic. Novel antifibrotics and anti-inflammatory targets are under development, and better understanding of genetic predisposition, which is very important. Maybe we could test the family tree to see who are more predisposed, so they can say out from parrots. Not but that will help parrots will develop that, and of course, personalized medicine approach. And then, of course, again, just recap the management will be antigen avoidance, cornerstones, anti-inflammations, as corticosteroid and immunosuppression, antifibrotic, natinine for progressive fibrotic HP, and then supportive oxygen, rehab, vaccination, transplant, evaluations. And this is for our patient that we present at the beginning. You can see at the beginning and after treatment. That's after 3 months. The lungs clear, the also normal, out of oxygen. Summary, HP is a preventable, treatable ILD when detected earlier. Accurate exposure and identification is very important. Multidisciplinary evaluation is important. And phenotypic guide therapy to maximize outcome. Thank you.
Thank you very much. It's an interesting presentation. I'll ask you a question. It's a might be a silly one, but I know we've seen lots of patients with like African grey parrots. And yeah, it's quite a mission to get them to stay away from those parrots because it's their pets for like years and years and they can live 30, 50 years. But are those avian proteins the same are they also supposed to get rid of their duvets or is it different?
Yeah.
Because there's no parrot feathers in the duvet.
No,
Right?
that's not. But I think that because the parrot is also a bit different. So now those with the parrots, again, I need to stress this, not everybody with parrots will develop HP. So now the parrots, of course, will be their feathers, the droplets.
Okay.
Yeah, dropping, which is always the problems. And sometimes somebody will be having parrots here, and then the neighbor on the about maybe 100 meters away. And the neighbor will be given HP than actually the owner of the parrots because they win. Okay. So the question, that's why we on the title presentation that when you start coughing, you need to seek for help. So most of the time you will know. But some people they have parrots and never have problem. You have a family group of 6 children, one only develop it, the others don't. So it's really more it's not well understood, but definitely genetic susceptibility actually play roles in it. So I think so the mechanism obviously depends on the amount of exposure, who actually got to the cleaning and everything. We have a way the domestic worker actually does all the cleaning, but then they want to develop the HP, the domestic worker never have any.
But now must they get rid of duvets as well?
Well, the question that now, then you don't know because all of them, our serology tests look for the feathers. Now, when that's positive, then you need to get anything that is linked to feathers. Whether the duvet and all this, everything must leave. Then you have to change the duvet because we have a patient that was young and she had pigeons outside. Yeah. And then everybody thought that was a problem, but while she having this slight beautiful duvets, that's what was flipping on. Yeah. And then she having ongoing progression, spending on higher dose treatment. So only on the history found that duvet was a problem, and then there was a quite synergy that actually the symptom got worse after she got a new duvet as a present, and now out of everything get out of control. So they take up message that obviously once you have HP, you get all the feathers thing out of your house. You need to get them out. That must be clean completely for it to happen. Even your neighbors, again, you must look at your neighbors. If your neighbors got parrot, you still might have it at the same. So you might need to discuss with the neighbor, or you might need to actually move up from your neighborhood. That's the reality.
I think I've got a conventional, but
yes.
I've got a question for you. So, what's the association between smoking and hypersensitivity pneumonitis?
All right. So I need to be very straight here. I'm a pulmonologist, so I don't condone smoking. So that's very important. So in the previous literature, obviously, is that there are patients who they did a trial where they look at the smokers and non-smokers. And they actually found that the smokers smoking tend to have protection against HP.
Why is that?
Well, I think I'm not so sure whether because if you look at all the smoking also involved the upper lobe. HP also involved in upper lobe. So if you look at the pathophysiology of smoking, you've got your neutrophil elastase, some related to that line. Yeah, but again, that theory has not hold water because we have seen people that smoking that develop HP. So I said this moment, that's why I have not included my presentation because it's just a dilemma. So if you got HP, starting smoking is not going to help you. Let's stay out of it.
I also have a question. You see manufacturers of duvets claiming that it's anti-allergenic. They have this material they put over and it's then actually effective against house dust mites, for example. So will this be effective against this? Does it depend on the diameter? What's the diameter?
No. I think Karen, yes, thank you for the question. I think these are two different things. I think obviously when they say hypoallergic, they mean in terms of the airway disease like asthma and things like bronchitis and everything. While HP is not actually allergic related, it's more kind of hypersensitivity. So the two are different. So when they talk about, they're talking in terms of allergies, patient that got asthma, hay fevers, and everything. While HP is more to do this, so they're not talking about in HP side. So they're always very. I remember that I think there was an incident where they actually took them to court for hypersensitivity pneumonitis, and they won the case because so they didn't say that you will not get hypersensitivity pneumonitis. Was not part of it, but they say allergies, asthma, and all of that.
So they're not blocking exposure totally.
No, it's not. But we don't know because the question that when you get it, you might develop that. You might develop other things like IP or eosinophilic pneumonias. Those are not yet known. So I think maybe they need to kind of maybe now. I think obviously I think the medicine has always evolved that well. That's why we don't do the idiopathic anymore. I think once later you could probably, once you can do a typing of HLA antigen, and then means somehow before you buy them, then you actually go to the labs and saying, can you check my HLA? Now, if you're having DR53, then you say, okay, I have DR53. I'm going to stay out of this because my risk of HP is high. And this was probably in line with the discussion we had last week from one of the AMPAT labs who discussed about the ethics about actually informed consent. Now, the question that you tell patients, don't buy Duvet, you're going to get in. And now, what if they buy the Duvet and they never have the HP? Or if they buy it, then they have HP? When do you do it? So maybe we need to do genetic counseling or HLA counseling. And then you have that test. And if that happens, the family means a family, we have developed them, then you test all the family members. And then they will have their bracelet say, no Duvet for you, no Pigeon for you, nothing. Something like that. Online, I see that we have a very new lady cry, a pulmonologist from UCT. How are you? Any comment?
I'm good, thank you. How are you?
I'm already been hiding. Thank you. Thanks for joining our presentation. So what's your comment?
No problem. Not really much of a comment, but it's more the discussion about when to actually biopsy all these patients. Because I think I was discussing with someone else, similar discussion about when do you biopsy them. Most of these patients, we don't biopsy.
Yes. I
It's
think
all inferred from the scan.
Yeah, well, if you have the history and everything confirming, then you don't need to biopsy really. So we don't really do it. And I think some of the cases, except if you have a CT scan like the first one that I saw you, and then they issue that because now the patient's on TB treatment and with the diffuse nodules, now you don't know what's happened. So normally you do a transbronchial biopsy on them. And also when you're looking for the lymphocyte, but most majority of patients, just treatment alone, you can actually get away with it. Yeah, so you don't need to have biopsy on them.
Okay.
I agree with you.
Thank
When
you.
are you coming to Counting? Are you coming back to Counting?
Yes, I am in the next month.
Oh, you mean you full time?
Yes, most likely.
Okay, great. Welcome.
Thank you.
Any other question, Okoli? The fellows.
Hi, everyone. No question from my side. Thanks for the presentation.
Thank you, Ratzi.
Thank you for the presentation. Can you hear me?
Yes, very well.
Okay, all right. Thank you so much for the presentation, and thank you for explaining why HP affects the upper lobes. That was always a question that I had.
Thank you. Any other question? Otherwise, we can call it a day. For all our people online, the presenter will be on podcast, will be available through our YouTube channels, and you can access them, and you can be able to play them over and over. Thank you so much. On the rooms, no questions. Can I exit?
Thank you. Bye-bye.
Thank you.
Thank you. Bye.